This is a training initiative to provide the oncology workforce with education and resources for the adolescent and young adult cancer community, brought to you by Elephants&tea and the AYA Oncology Education Working Group. Each month, we bring in an expert speaker or speakers to share information and insights on topics that are really relevant to AYAs with cancer. Each of our sessions are recorded. So you might have heard that just pop off. I might have missed my own first introduction by not hitting the button. So thank you to my team for making sure that that happened. But each of our sessions are recorded. You can check out our library on our Power website of all of the previous seasons. It all exists there. So you can revisit any of these sessions at any time. You can also send them to colleagues or use them as additional education tools to look at particular topics and just continue that knowledge base and education for AYAs. Just a little bit of housekeeping, and then I am going to stop talking myself. But first, a huge thank you to our sponsors for supporting AYA Power, our founding sponsor, I'm Not Done Yet Foundation, and our supporting sponsor, Azi Pharmaceuticals. As always, there is a Q&A button at the bottom, I believe. So we hope that this will be a very beautiful discussion as we talk about this topic with our amazing speakers and facilitators. So please make sure that you are dropping your questions in and really engaging. This is what this part of the community is for and what we really look forward to as well. So thank you again for being here. Thank you for the incredible work that all of you do supporting young adults with cancer. And with that, I will pass it over to Dr. Mike Roth to introduce our speakers today.
Thank you so much, Kayla. And as you were talking about getting to the end of season 3, it made me a little bit sad, but my son is watching the Rocky series, and Rocky 4 is one of the best Rockies. So season 4 will follow season 3 here. And thanks for sticking with us for 3 seasons. To those who are new this season, thanks for joining us. And we've really just been privileged to have wonderful speakers and wonderful interaction. So on that note, our grand finale for season 3 is really outstanding in terms of our speakers. And I won't put too much pressure on them other than to tell you that I have had the pleasure of hearing them speak and asking some important questions to both of them, and we're in for a treat today. Please put your questions in the chat, in the Q&A. We will also have time for active discussion, and that is a really important part of the discussion and the talk today. So on that note, I will introduce our 2 speakers who probably don't like to be introduced formally, but I will do so anyway. So first, Scout is our first speaker, who is the current executive director of the National LGBTQI+ Cancer Network, a sought-after advisor on LGBTQI+ health issues, and an openly non-binary and transgender father of 3. They spend much of their time providing technical assistance for tobacco and cancer-focusing organizations interested in building equity for all. Our second speaker who will follow Scout is Dr. Nina Francis-Levin, who is a research associate and instructor at the University of Michigan in the School of Social Work, Department of Internal Medicine, and the Health Sciences Scholar Program. Nina received her PhD from the Joint Program in Social Work and Social Science at the University of Michigan. Recently, she completed her National Institutes of Health sponsored T32 postdoc fellowship in the Division of Metabolism, Endocrinology, and Diabetes, that's a mouthful, also at Michigan Medicine, and formally completed her NCI-sponsored T32 predoctoral fellowship at the Cancer Center there. Her interdisciplinary research is invested in improving psychosocial health outcomes among adolescent and young adult cancer survivors, with a specific focus on multi-level interventions that target reproductive health service delivery for family building after cancer. As an early career scientist, she contributes expertise in supportive care delivery as it pertains to the unique experiences of underrepresented AYA populations. Welcome to the 2 of you. Scout, I will thankfully stop introducing you guys and pass it over to you.
Sorry, I'm just being smart in the comments. Thank you much. I certainly appreciate it. I also actually really appreciate the focus because I feel like the AYA queer population is something I'm very rarely see any kind of specific focus on. So I'm really happy to be here and be discussing that very specifically. Um, so I've got a couple things, and I know that you had a presentation before this was also focusing on this, but I mean, the first thing I just want to do as a kind of starting point is to make sure we're understanding that this population we're talking about, not necessarily of people with cancer, but AYA, queer identified, is one of the fastest growing population subsets, certainly in the United States, that exists right now. So, just to say over the last 10 years, as the full probability Gallup poll has been documenting, there's been a really rapid uptick in the number of people who are identifying as queer. And that is largely driven by, they only do adults, but the youngest adult cohort in there. So just to show you where we stand right now, this is full probability. So these data hold from Alabama to New York City. It is about 23% of the general population is identifying as part of the queer communities. So, we often think that we might be talking about, a real minority population or a sliver population, but it's not the case when it's practically 1 out of every 4 young adults. And then if you look at the generational changes in identification, of course, the greatest generation is the lowest, then you go all the way up to the young adults. That's the highest. And one presumes if you followed that to the youth, it would get higher still. So, just looking at the rate of the curve, it's probably 1 out of every 4 or more than 1 out of every 4 of youth across the full country are identifying as some level of queer. So it really goes beyond the idea of feeling like we're dealing with a niche population, and instead you're dealing with a rapidly growing set of communities. And they're rapidly growing even in the face of increased hostility with the population because if people aren't familiar, the number one type of topic for attack ads in several election cycles now by Republicans has been transgender people. And the content, the number of laws that have been introduced, statewide legislation against trans folks, has moved from like 200 a year up to over 900 a year this last year. And one of the major thematic points of those laws is to restrict access to care in your adolescent years. So we're now not only talking about increased identification, but doing it at the same time that a lot of metrics in the world are pulling back from support. And I think a lot of people are familiar with how federal funding has now been, to be honest, kind of weaponized, and people are threatened that all their funding will be organizations, major organizations, including cancer centers very specifically, have been threatened that all their federal funding will be pulled if they do things like provide care to trans youth, things like that. So we have not seen a moment that matches this level of historic as far as rolling back protections. And I think that's an important thing. It's not like we want this to be a political talk. We don't. But this is a political reality in the lives of the people that we're talking about. They don't have a choice of ignoring it. So, as practitioners, it means that if we're trying to come to the table to support this population, we also don't have the choice of ignoring it and just saying, like, we don't care about politics. We have to understand the factors that are influencing the population that we're dealing with. But in the face of all of that increased opposition, historic increases, nonetheless, the number of people who are youth who are identifying as part of the communities continues to, like even just in the last year, it dropped by 0.2% from 23.2 just down to 23. So there was a minor amount of contraction, but really only minor. So to be honest, I would say that these data alone are some of the really exciting data about whatever in the world is happening politically against the queer communities. You have enough young people at their most vulnerable moment feeling secure enough that they can disclose that they're members of these communities. And that is actually, I think, one of our most optimistic signs for the fact that the future will be more welcoming. And also something that it's interesting because usually I have to convince, like I was just on with a pharmaceutical company right before this for their Pride programming. And I was like, if you're trying to tune to serve your clients of tomorrow, you have to work with the kinds of things that are a general starting point for this population today. But of course, if we're starting with an AYA focus, I don't even have to say tomorrow. It's really the people we're serving today. And it really, I know that, We're going to talk about some of these strategies a little bit later, but it really also brings up, do we have core competencies with the population? Like, for example, are you really used to introducing yourself with your pronouns? Do you understand the difference in how it comes across if you ask someone their pronouns or if you introduce yourself with your pronouns? One of those signals safety. The other one asks us to disclose something that might make us vulnerable before we've gotten a signal of safety. So, again, we're going to be going to strategies a little bit later related to this, but I wanted to give us at least some of those starting points related to the population. And I would also say another piece about it. People may be familiar that in the queer communities, often the bisexual communities are actually the largest subset, not often the people most talked about, often a less kind of focused on part of the population, but nonetheless the biggest part of the population. So if you look at some of the data, particularly Gallup as an example, and you're looking at that 30 and under range. So and again, it's 18 to 30. In this case, they didn't do adolescents. Uh, we're really talking 2.9% identification lesbian, 2.5 gay, 16.1 bisexual, and then 3% transgender out of the 23% total. So it gives you a sense that in that metric, this is a largely bi and pansexual, being a synonym for the word bi population, which also means that we should be kind of tuning our outreach materials and things like that to reflect that. But if you look at some other data that are out there that may have asked the question slightly differently, you actually see, interestingly, that over half of the youth population, and this is coming from the Gay, Lesbian, Straight Education Network's most recent school climate survey, over half of their youth population are identifying as some kind of non-binary, gender non-conforming, or transgender. And the reason why that's a really interesting point, it differs from Gallup, which probably has to do with how the questions were asked, right? But the reason why that's really interesting is because usually the gender nonconforming subset is a much smaller sliver of the queer communities and people are not as familiar with it. But now, if you're talking about the AYA population, suddenly this, depending on how the questions are asked, this could be over half of the people that you're dealing with, which really shows that we've got to have good skills with the population. For example, are you really familiar with referring to people by they, them as a pronoun kind of thing? These at this point are really baseline skills for dealing with that population. Okay, so that's just some big demographic stuff as a little bit of framing to start. Now, digging into cancer very specifically, we actually, people might be familiar that pretty much 100% of queer health research was terminated last year. Much of it was reinstated, but after a gap that was like 5, 6 months. And as you can imagine, firing your lab and then trying to reconstitute a research project 5 or 6 months later does not exactly create a lot of momentum. At the same time, there were attacks on surveillance, and a lot of surveillance was suppressed. So that means that we're not going to get queer data out of a lot of the federal surveillance instruments any longer. So there is, again, a wholesale level of suppression of the research that is out there. And knowing this and also realizing that it was a historic year as far as, again, uh, policies that were directed at limiting our community's level of resources or access or welcome, things like that, we decided to do a side quest project and completely unfunded, trying to think through with, some of the researchers that had extra capacity and some of the community partners, 93 community partner organizations we got to volunteer to help with this. We decided to conduct our own side quest survey on how the community was doing. And we've got over 8,000 total respondents. Of that, over 1,000 of them cancer survivors. And I can't, unfortunately, right now, separate this out into the young adult cancer survivors yet, just because we're just starting to dig through these data. But what I will say is this, that we're seeing a lot of the same patterns across lots of subgroups. And we do know, as is very key in the public health world, that anything that happens younger in life has a bigger impact on your overall trajectory. So if you experience a problem with health younger in life, it's going to have a force multiplier effect as far as what kind of impact it may have across your life. And unfortunately, I'll give you a preview into some of the findings we're seeing from the cancer survivor subgroup of this survey. But I will say this, as we predicted, potential, considering the year that the last year was, unfortunately, this is the biggest set of population shifts downward on pretty much every metric that I have seen in my professional career in one like 13th month window ever. So I think the biggest thing, and we'll go into some of the details, is to say that we have all of the existing health disparities that existed with the queer communities, all the existing cancer disparities. We know all of those are multiplied when you're at a younger age. And let me just do a side point here. I presume everybody is very familiar with there's one real fundamental difference between growing up queer and growing up as some other kind of stigmatized and discriminated against population. And that's that in most cases, you're born into a family that already shares that same trait and thus has figured out how to survive as best they can and help mentor you in survival strategies. Not always the case because, like, maybe you have a disability and that's not the case. But in most cases, like you're the same race, something like that. But of course, with the queer communities, that's not the case. And what we do know then is that that issue of feeling like you're different, like you're an outsider, like you're discriminated against, when you realize that at a very early age, it leaves you so much less stable. In particular, it's one of the big drivers behind the really high suicidality rate in the queer communities, and a lot of that is early life suicide attempts. And we also, have had some long-standing research showing that in all these cases, literally, if any young queer has one welcoming adult in their life, just one, it lowers their suicidality rate eightfold. So we also see how desperately we're searching for anybody who accepts us for who we are, and what a big difference that can make in someone's life. We know just large scale in across the communities in general right now that many more people are becoming more familiar with queer youth specifically because again that 23% the level of identification is what's driving a lot of people where they're like, I have a queer nibbling in my family or something like that, which is a non-binary niece or nephew. Or, I have a queer kid, I have a non-binary kid, something like that. So a lot of people are becoming more familiar with our population through that, but it's not exactly like it comes with a guidebook on how to care for queer youth. And if there's one important thing to say here is that we're in such desperate need of welcoming adults to help us through that very vulnerable time. Add in the concept of a cancer journey on top of it, and the need only really escalates further. So if you're anywhere near people in this population, it's a real kid gloves, baby chick kind of softness and care because it's that level of vulnerability baked into the experience as so many queer youth have without even having cancer added on. Okay. So with that, I know I'm yammering on here and I got to come to the end of my thing and I still haven't told you about the out survey stuff. So again, understanding we don't have it separated out into youth and adult, but like I said, worst I've seen just as examples that across the cancer survivor population, anxiety rates, increase in anxiety over the last 13-month period since the inauguration have gone up on average about 75%, 3 out of 4 people. On average, increase in depression is about 68%, so almost 7 out of 10 people there. People are reporting PTSD symptoms. An average of half the population is currently reporting PTSD symptoms. Not even counting that about half of this community is reporting increased sleep problems. We've got probably about 3 out of 10 reporting increased compulsive behavior problems. Um, and interestingly, when we talk about these like risk issues related to PTSD and things like that, we know that, if you have a certain number of stressful life events per year, such as moving, changing jobs, things like that, and they don't have to be bad, but they're stressful, um, that most people might have 1 to 3 per year. And if you have like more than more than three, you're really at an increased risk for PTSD. Well, half of this community actually had more than six of these stressful life events happen in the last year. So that PTSD risk for the population is really starting to go through the roof. We also have over a third, again, of the cancer survivors reporting declines in housing, income, or job security just in this one window. And 8 out of 10 were worried about future declines. A little under a quarter of these people is just one bellmark indicator of how things are shifting. A little under a quarter of this population lost income just in the 13 months since the election. Again, the idea that that would happen to that many people in just one 13-month window is really, really big. And, not even counting the fact that we had a big workforce piece, and a lot of people are have fears for their jobs and or have lost their jobs because of the changes in funding and resources available to these organizations. We also see that almost half of this population was considering moving. A lot of that has to do with queer welcome in their area, anti-queer laws in their area. But extrapolate that now, these are already cancer survivors and are people in cancer treatment. When you move, you lose all of your existing resources and you have to rebuild them up from scratch. So again, another really destabilizing phenomena. And 67% of the group said they have increased medical mistrust just over the last 13 months alone, including the fact that this is increased for the Gen Z respondents compared to the general population. And the last thing I'll just say about this is out of all of this, these numbers are frightening as far as what it means for our cancer, patient community. Doubly frightening when you think about the AYA population. But we did find something that has since been also borne out in another research study we did of trans folks. And it is the anecdote to this, or the factor that most increases resilience. And that single factor that most increases resilience is how socially connected people are to community members and the people that they feel safe with. So that is the one thing that if that was the case, you reported less problems on every single other metric. So it really kind of begs the question of in this population, should we be doing more, particularly for people undergoing a health event like cancer, to try and help them build that level of social connectedness and safety? Because it's not usually the kind of thing we think about in cancer care, but it might be the thing that's needed the most. With that, I'll shut up. Move on.
All right. Well, thank you so much. Let me share my screen and make sure that it's set to. Is that looking good to everyone?
Yes.
Okay, great. Well, thank you so much, Scout, for starting us off with painting that big population level picture, as well as sharing some of the most recent findings from the OUT study. My name's Nina. I have no disclosures. I think it's so great that this is the topic of the month because it's June and it's Pride Month, so it's perfectly fitting. And today I want to talk a little bit, coming down to a more micro level, thinking a little bit about what this looks like in practice, some of the calls that Scout is making around starting to think about the extent to which we have core competencies for engaging with LGBTQIA young people in the context of cancer care delivery. So I just want to kind of come back to basics for a moment. This may be a refresher for some of you. This may be new for others, but I think it is always worthwhile to critically return to some of the core constructs that are important to the population we're talking about. So first, when we talk about sex, we're talking about biological sex, usually determined at birth, based on a combination of multi-level constructs that are all on their own spectrum. So genetics, chromosomes, internal and external anatomy, and hormones all make up biologic sex. Sexual orientation is a multi-level construct as well that encompasses one's romantic or sexual attraction, which is related but distinct from behavior or activity. So attraction refers to whom one might be drawn to romantically or sexually. Behavior refers more to sexual activity itself. And identity refers to one's intrinsic sense of self, what they might call themselves, how they might see themselves as a participant in a particular culture. And I think some examples of how these things are connected but don't always overlap. In one case, men who have sex with men is a MSM is a clinical term. Referring to some men who are sexually active but don't necessarily identify as gay or bisexual. And another example is bisexuality. I'm so glad that Scout uplifted the salience of bisexual identity under the LGBTQ umbrella. Sometimes when someone who's bisexual is partnered with somebody of a particular gender, they may be attracted and sexually active with that person, but that doesn't mean that their identity is no longer bisexual. So we have to really kind of understand and tease apart these different constructs. And then when it comes to gender, the kind of distinction here is between one's identity, one's intrinsic sense of self, one's how one feels along a kind of spectrum of gender versus expression, which is how one presents, what one wears, how one likes to appear, and this may intersect with sex for people who are transitioning medically, who want to change their expression through a number of biologic mechanisms that they want to change as well. So as I was thinking about this presentation, I kind of was thinking of like a useful little framework, and I came up with this idea of a pride framework for thinking about supporting disclosure with AYAs, although I've sort of reversed it. So we'll start with E and end up with P. And the first one, E for emergence, I think is the most important consideration for supporting identity disclosure for young adults. One of the things that makes AYA LGBTQ folks different from the adult cancer population is that, as Scout talked about in many ways, these are identities that are emerging concurrently with cancer diagnosis and treatment, and in some cases are being shaped by cancer and the experience itself. I think that sometimes the literature and maybe ad hoc clinical discussions have this imagination that LGBTQ patients are fully formed in their identities. They're this internally coherent, static identity. And as clinicians, we just need to appropriately ask them what that identity is. When in the reality, this is a period of time when young people are exploring their sexuality or may not be able to explore their sexuality because they're going through cancer treatment and are immunodeficient, or may have an inclination that they might be gay or queer, but they've never had sex before. They may have an attraction, but the behavior doesn't match. So I think it's really important. And my research and some other research, and I've included some citations at the end, has also found that cancer itself can sometimes influence how people experience their bodies and their sexuality, with some people exploring a more expansive gender when they lose their hair, or sometimes folks with breast or chest resection may, experience their body and their gender differently. So this changes over time with new experiences, which I also think is really key to the AYA population. You may start, seeing a patient when they're 13, and by the time their treatment and surveillance is done, they're 21 years old, and their sense of their identity and their sexual experiences may have changed greatly in that time, and they may identify differently. So this emergence, I think, is the most unique feature about supporting identity disclosure for AYAs, different from the adult population of LGBTQ folks. So D stands for definition. Definitions are expressions of culture, and culture is fluid and ever-changing. So definitions change over time. And I think it's important to remember that as we collect data about, our patients that we're seeing, our research participants, labels can be empowering at times or limiting, or both in different ways. So being able to classify the patient population or an individual patient is it's useful, but it can be limiting in a way too. So just being mindful that somebody being able to write down on an intake form their identity still doesn't fully capture the nuance and the complexity of all that they are and that they're going through, and keeping that in mind with young people, I think, is really important. And so just some clinical considerations for intake forms for research. consider formats that allow for updates as needed, consult with advisory boards or stay apprised of policy, or when we had the SGMRO to look to. um, and so make sure that including time in your clinical workflow to periodically update labels, definitions can sometimes be really important. And then also make sure to match the accurate response category with the question or prompt. For example, like we talked about before, make sure that when you're asking about sexual orientation, the response categories correspond with that and not necessarily with sex or gender identity. So coming back to those distinct yet interrelated constructs. And then I just did a little screen grab from a survey that Dr. Zebreck, who's on this call, and I are about to launch. And maybe this could be helpful as a screen grab. This is how we're using our categories at this time. This particular screen share is from a screening portion of our survey. So here we didn't include prefer not to say because that wasn't right for this particular data collection, but in your case, including prefer not to say could also be useful. But allowing for select all that apply if your statistical analyses are able to do that is great. In this case, in a very small screening survey, we can. So again, just thinking flexibly about what your aims are and how you want to deploy this kind of data collection specifically to your case or your clinical population, clinical practice is important. And then I also included this, just thinking about asking about pronouns or honorifics. And this is something, and since I'm not a clinician, I'm in the research context, I always do this before interviews so that I know how to address people, even if we haven't asked them that on their demographic survey, because we don't need to know that for whatever reason for that particular component of the survey. But this improves the rapport that we can build over the course of the conduct of research or clinical encounter. So I is for intention. I think that the purpose for asking and inquiring will guide the what, how, and when of the information being asked. And so being really clear for practitioners clinically, why are we asking them this question? And also being very transparent with patients. Why are we asking you this question is important. Do we need to know their identity so that we can, connect certain patients with peer support services, or do we need to know their sexual behavior and their sexual activity so that we can introduce risk screening or other kind of safe sex counseling? So having a really clear reason for asking certain questions, and to the extent that it's fitting in the context, also telling patients, hey, we're asking you this question so that we can do XYZ, connect you with these resources, or respond to these needs that you may have over the course of your cancer care, can be really helpful so that patients aren't just providing this potentially vulnerable information kind of into this unintentional void. And this idea of false flagging, I think, is really important. I think especially, sort of more in the tone of the previous administration fostered this a little bit more than the tone of the administration currently. But the issue of wanting very much to be inclusive and wanting very much to express a kind of openness and safe space, but not actually being clinically prepared to deliver on those services or respond appropriately or effectively, introduces this idea of false flagging, like waving the pride flag, but not actually being able to respond, or saying, you can ask me anything. And then someone asks the question and you really don't have a response or a resource. So we want to avoid that. We want to share and be prepared to respond if we in fact are going to signal that and invite that kind of interaction from young patients. Which brings me to resources. So referrals, finding champions within your institutions and broader networks is always really key. And I think this can be both within the cancer space and beyond. Adolescent health, I know at our university, has been a major ally for our AYA program, even though they see more than just young adults with cancer, they see all young adults. So finding your champions and your allies is really important. And also being transparent with AYAs about your scope of practice and next steps. So if the question is, if there's a clinical conversation about a sexual activity, let them know, hey, if you're going to share something with me that I can't answer, I'm going to be sure to get you that answer. We're going to take this next step or that next step, or I'll provide you the information and you can take the next step. So that transparency, I think, is really key. And then also making resources readily accessible so that access to these resources is not contingent upon a patient's active disclosure is really important. So finding ways to share these resources with everyone, and then for those to whom this is applicable, they will be able to see these resources, however that fits in your clinical context, whether that's a web page or flyers in the clinic. That can be a really great way to minimize the pressure to have to disclose in order to access services. And then here's a list of resources that I put together. It's not exhaustive, but some good places to look if you want to do a screen grab. Just some useful tools, and I can also paste these in the chat. And then finally, practice, P for practice. I think that rehearsing sometimes can actually feel awkward, but we're having a rehearsal of these conversations just as one does with any clinical competency, I think can be really useful. And it's good to include clinic staff in trainings and rehearsals as well. I know from my research and others, sometimes we focus all of the onus and importance of skilling up physicians, which is important. But there are so many other players that AYAs interact with, phlebotomists, the front desk, that actually can really have an impact on one's sense of safety and welcomeness in the space. So those are champions that are not to be forgotten in these efforts. And then I think practice makes usable, not perfect. I think AYAs don't need perfect, they need authentic. And if there's practice and effort into just getting the language into your mouth and saying it and not being caught off guard. And finally, I think practice helps achieve a useful neutrality. I think there's walking this line with tailoring care for LGBTQ young adults between making services that are personalized and tailored to their specific needs and experiences, but also not setting them apart from the rest of AYAs in a way that is overly over identified or over determined, but to really just be ready to receive a disclosure with the same neutrality that one might receive the disclosure that somebody is cisgender, heterosexual, and sexually active. So with that, I think that's kind of my proposed framework toward improved clinical interactions and psychosocial outcomes. Some of my references here, which I'm happy to share. That's all.
Yeah, thank you, Scout. Thank you, Nina, so much. I have several questions, but we want to give other folks an opportunity to start off. So maybe, Scott, I'll kick it over to you. I think there may be a couple questions in the chat and Q&A.
Yeah, so
I see. Sorry, go
yeah,
ahead.
the first one was if you can talk a little bit more about mistrust. Why does that exist? How can we get around that? Um, we all know that we can do better. And thinking about this not just from a broader perspective about the healthcare team, because we do have a lot of people on the call that are from different roles within the team.
Yeah, I think it's a good question. And the nice thing is the answer to that is so simple. It's just, again, not rocket science. There's very few people in the queer communities who, if you haven't experienced someone treating you with lower respect because you're queer yourself in the healthcare world, you usually have close friends or family that have experienced that. So, which unfortunately creates an associative effect related to the trauma. Um, so we are concerned about that. And then you add in like these political headlines that we're being bombarded with left, right, and center. And we're increasingly concerned about whether we're going to be treated with dignity and respect. And, as I often say in my some of my talks, it's like, is today a good day to be disrespected while naked? The answer is rarely yes. And that just means that even for someone as motivated and educated as me, I'm behind in a lot of my screenings. And now you take like an adolescent, and they, don't nearly have even the level of ego development, all that sort of stuff. So it just makes those things much harder. So the medical mistrust, honestly, it really boils down to, do you go home and put a red hat on and are actively fighting against kind of like the rights and resources of this population? Or are you one of the overwhelming majority of medical professionals who actually cares about providing dignified care to everybody? And and the nice thing is, it's really simple to convey that to people. You can do it via a wide variety of ways, but to be honest, the simplest and fastest is that whole, "Hi, my name is Dr. Scout. My pronouns are he, they. Nice to meet you." That doesn't just say you're aware of pronouns, and for that, since I have they, it's an unexpected one, but that doesn't just say that, here's what my pronouns are. What that's really saying, the meta thing you're communicating there, is I understand that people experience discrimination based upon this factor, and I want to be try a piece of trying to fix that. And it's allowed, and we also know that this, if you say something like that, racially minoritized communities also realize, oh, this is on the side of the angels, right? Instead of the side of the people who are trying to get rid of all efforts in the United States for racial equity, kind of thing. So it also conveys a message that's larger than the specific subpopulation you're talking to. So the big question is just, are you doing anything we can see to assure us that we will be treated with respect? And we get it, things are going to go wrong. But if things go wrong, do we have recourse at your organization? Or is it like so many other places where we can complain and people be like, I don't care? So, basically, are you doing anything? That can be putting pride stuff up. That can be putting a sexual and gender orientation data collection on your intake. That is, using the right way to ask it and not just your own way to ask it. That is talking about queer specific activities you might have at your organization. I remember the first time my dentist was part of a health center that offered queer transgender swimming nights. I was just like, this is amazing. I feel valued for the first time and seen instead of, just as someone who might be kind of pushed out of lots of medical places. So what are you doing? And are you doing something so that we're not guessing? And the simplest move on that, introduce yourself with those pronouns, and you will automatically be on the side of the angels.
Yeah, that's great. I want to add also that I think a little more micro variation on mistrust. I think with the AYA population and disclosure, and a number of other other aspects of AYA life that young people think about disclosing to their doctor or not, is the question about, will my parents know?
Yeah.
And of course, that can vary based on the state that you practice in or the policies of your institution. So being prepared, like kind of proactive with that knowledge, is really useful. And then sharing that as you would in establishing with any patient, hey, if you tell me this, I don't have to tell your parents that, and I want you to know. Or if you tell me this, I will have to. So just being proactive with that transparency, I think, can improve that person to person level trust as well, which has an effect across some of those broader levels of trust with the healthcare system.
Yeah, that's really helpful. And Nina, I want to follow up with a question that I struggle with in my practice. We focus a lot on peer connection for our AYAs and the isolation that goes along with cancer treatment. You mentioned this in your talk a little bit about connecting with folks who have similar experiences, but not leaning in too far and excluding folks. And h- how do you balance that? How do you navigate that? Acknowledging that there are, perhaps fewer resources for certain populations. What would you recommend to providers?
Um, that is a really good question, and I think it's being thinking of wanting to connect an AYA into a peer group where they can be a whole person, including their identity, rather than just because of their identity. Or, some people may be really driven to meet with other people specifically who are queer for that reason. And some young people may just want to be in a space where it's perfectly safe and comfortable to be queer, and there may or may not be other queer people. So, learning more about what that person is really needing, I think, taking a really person centered approach before troubleshooting to find resources or make connections. But I think, just like in any context, in the cancer context, nobody wants to be solely defined by their sexuality. And so, yeah, making options available. I have this other project about LGBTQ cancer patients and their pets, and using pets as that point of entry to connect people who are queer, but their commonality is their love of their pets. So there's these kind of like side doorways to bring a space for community to connect without being like over determined about this you are only here if you are this kind of queer or that kind of queer, etc.
Yeah, that's really helpful. And I will likely follow up with you as I usually do
Yeah,
afterwards with additional
yeah.
questions. So Scott, maybe I'll pass it over to you for some additional chat questions.
Well, kind of a little bit along the same lines as you're starting to give us some tools or suggested questions, like you're saying about ask about pets and things. There was a question in the chat about the logistics and kind of how you roll out a rehearsal in clinic and how do you operationalize that with the healthcare team?
I wish I could actually
Yeah.
sorry, you want to take that? I just
No,
didn't
no,
mean to
go, go,
interrupt.
go, go.
I wish I could show you a video that one of the cancer centers did, and they did a really great job of it just with their own providers, and it was filled with so many awkward moments. And one of the things I just really will say, providers, especially doctors, MDs, do not like to be out of their comfort zone. They don't like to be in an area where they don't know anything. But on the other hand, whenever you're working with underserved populations, if you're not in a soft area, then you're just not stretching yourself enough. You're just playing to your safety game, and that is not the full set of communities you're trying to. So, I mean, and we did some dynamic practicing with those rehearsals there with that cancer center. And so, the first thing they did was they had some of the influential people take part as the actors in it because then when they're kind of like embarrassed and awkward and things like that, it normalizes it for other people. The particular things they went through, there was a few different ones. The one on the video was someone coming up and presuming that X person was your patient because maybe it was a gyn cancer facility and that person presented as female, but it actually was Y person who presented as male as the person. And then or presuming someone's partner what someone was someone's sister instead of their partner, all those types of things. So, what you want to do is you want to get into some of those classic trouble zones, like presuming someone has body parts they don't, not doing an anatomical inventory, using the wrong name, using the wrong pronouns, getting someone upset because they've corrected pronouns 30 times with your, stupid cancer center so far, and it's still getting wrong. You know what I mean? So just make sure you get into those areas, normalize, the awkwardness, hopefully by actually, showing that influential people can be awkward, but also normalize the recovery related to it. So obviously you want at least one actor in this whole thing to have some sense of how to get out of the mire of embarrassment. And, the big thing that we always say related to recovery is don't make it a bigger thing than it needs to be. Like you're not going to be apologizing, an hour later. Just be like, "Oh, I'm so sorry. I got the pronouns wrong." Bleh. I promise I'll try my hardest to do better and then keep going. And a little tip is with something like that, overuse them for pronouns. Like you can fit pronouns into a conversation more than need be if you want. And every time you do, you're building trust as long as you get it right. So, like, just, use those little things to build that trust right back up. And I don't think, particularly with the youth population, no one's expecting perfection by any means. But what they're trying to listen for is there a sincere attempt to see who they are and respond to that? So again, perfection's not our goal here. It's just genuine as, so I'm at authenticity and a real attempt. And if you're out of your comfort zone, show us. That makes it easier because we're out of our comfort zone as a patient being in, a cancer oncology, interaction in the first place. It's very humanizing.
I really appreciate that insight about the overuse because that's so antithetical to what we would think, especially if you're coming into it, it is something that someone is uncomfortable with, you shy away from it. Um, and it's not just to help the clinician or provider get more comfortable, get more used to it, but like you were saying, it shows that effort of trying to, really do right by
Yeah.
the patient and show that
And
they
the
care.
opposite is so loud. If people
Yeah,
think you're avoiding pronouns because you can't get it perfect, we can smell that a mile and we can tell. And you're conveying that you're really uncomfortable. So
right.
stop it.
There's a lot to follow up. I'm so glad my friend Trisha put a really thoughtful comment in the chat box, and I don't want to do it, or not do it justice. But I wanted to kind of build on some of Trisha's comments regarding the AYA population is like a heterogeneous population, right? A 15-year-old is not the same as a 39-year-old, and folks come from different backgrounds, How do you think about that when it comes to your identity and putting folks together, based on identity who are, as a teenager with someone who has two kids and like I, I struggle with that. And again, Nina, I think it's coming back to that same question, but how much is your identity kind of your link versus, really just finding that safe space for folks?
Mhm. Yeah, I think that's such a good question, and it's a constant exploration and balance in a way. And I think that excuse me, can you hear me? The I think that the issue of the expansiveness and the ever-growing kind of like inclusive age categories, plural, and developmental stages of AYA is an issue, whether we're talking about, financial support, where some people are, working and have a 401(k) and some people are on their parents' insurance and they're all AYAs. So I think that, in the case of the topic of sexuality, I think it's perfectly okay to maybe try to group people more or less by their developmental stage broadly, or let them choose what feels appropriate for them, but not shy away from not having to have it be a monolith, like all bisexual AYAs with this diagnosis meet in this group. That being said, I think the queer community has a really rich and longstanding tradition, as Scout was talking about chosen family and multi-generational connection, and supporting younger people as they make their way through a kind of well-worn path of self-discovery outside their bio families. So I think, that's kind of an argument for both sides, but just being intentional. This is either a group for people in a shared developmental space with their sexual identity and activity, or this is intentionally a space for multi-generationality and connection.
And I know we're close, but just add a little bit onto that. Those are all excellent points. And I think the thing to walk away from with this is to understand that these are people with compromised life chances in the first place and a very complicated and intense medical diagnosis. So the one thing that it calls for is more rapport building and more listening. We can't say this group is remotely homogenous. It's like coming up with new acronyms, new labels, everything like that on a daily basis. So you aren't going to understand the details. Even as someone who's a professional trainer on this population, I'm learning new stuff every week. So this is really the moment for humility, but extra effort for connection, because you have to understand the vulnerability means these people are looking for any supportive resources. You can have the choice to be it if you put in the extra effort, or skip that opportunity if you don't. And you're again leaving, someone who's been kind of like half crushed by life sitting there without someone else trying to lift them up.
I was going to attempt to sneak in one more question, but I think that's a perfect place to end and pass it back over to Kayla. And we just want to thank you guys so much for being open, being willing to share with us, and really just making sure that we're informed. And there were so many key lessons about being okay with being uncomfortable and making
Yeah.
sure it's a safe space. There's just a lot to make sure that we bring into our practice and we don't just hear it on a talk like this, we actually move it to action. So thank you guys. There's obviously, I tell everyone when you guys do a really good job, and Scout, you gave grand rounds at MD Anderson a little while ago. Unfortunately for you guys, you keep getting invited back, perhaps in different settings, and that will keep happening. But thank you
No
guys so
problem.
much.
Thank you.
Thank you so much.
Go make great changes.
Amazing. Thank you both so much. Mike and Scott, also thank you for facilitating such a lovely discussion and conversation. And I completely agree that I feel like whenever we wrap up one of these sessions, I'm like, and part two is coming, like, and here's the next session and the next part. So please, everybody, stay tuned. I will drop in the chat. As always, we are looking for feedback on our Power program, on all of our sessions. We are looking for insights into what else we could be doing, what else you would have wanted to learn or hoped to learn. And so please, if you have a chance to fill out that anonymous survey, we would absolutely love that, particularly as we are starting to plan for season 4. So a huge thank you, such a beautiful way, I think, to wrap up the season. Nina, Scout, thank you again. To the team, to everyone that's been putting this on for the last several months, just a huge thank you. And everybody stay tuned for what's going to come next. And I wish you all a good rest of your week and weekend, everyone.
Thank you
Take
guys so much.
Bye, everybody.